I am professor of pediatrics at Mount Sinai at the ICANN School of Medicine, and I'm director emeritus of the Division of Pediatric Endocrinology and Diabetes. And growth hormone have been one of my specific interests over the years, especially growth hormone deficiency. The majority of the patients I see clinically will have issues with growth. So I thought I would start by giving you an actual example of a baby we were called on consult on just the other day. And this is a baby that the neonatologists have called us, a baby who's a few days old and has jaundice. The baby also, as every baby in the United States, has a newborn screen. And the newborn screen, they check for thyroid function tests. This baby also had a low thyroid function, measuring with total T4 or total T3, but without an elevation in TSH. When we went to see the baby, this happened to be a baby boy, and we found that his penis was somewhat smaller than we expect, even in a newborn. Then we repeated the thyroid function test. They were indeed low. We also checked the cortisol production, and that was low. And that is really suspicious of a baby who has congenital problem with the pituitary gland and congenital growth hormone deficiency as part of that. Because we suspected that, we recommended to do an MRI of the pituitary gland. And what that showed is that the pituitary gland was in fact quite small and did not have the posterior part of the pituitary gland was in a different location than normal. It's called an ectopic neurohypothesis. So this is a baby who has not only growth hormone deficiency, which is congenital, but multiple pituitary hormone deficiencies. Congenital growth hormone deficiency as part of other pituitary hormone deficiencies. It's called multiple pituitary hormone deficiency. That happens to be not so common. That's quite rare. More common is the child who comes in for a stature evaluation because he's not growing well or she's not growing well. And as part of the evaluations, we exclude all kinds of other causes that could impair growth, nutrition, chronic illness, etc. And then when we finally wind up and we test, we find that the patient has growth hormone deficiency. That's by far the most common finding. And in the vast majority of cases, it is, quote, idiopathic, which means we don't find an organic cause for it. And most of the time, it is also isolated, which means that there aren't any other pituitary hormone deficiencies. As you're probably aware of, growth hormone deficiency is not an easy diagnosis to make. What we do is we measure baseline bloods to exclude all other potential causes that could impair growth, and then ultimately wind up measuring indices of growth hormone production, IGF-1, IGF-BP3. There is no universal good assay for that. It needs to be interpreted in view of the patient's weight and pubertal status. So growth hormone is secreted normally by the pituitary in little bursts. So random level of growth hormone is not helpful. If you happen to get a growth hormone level that is high, that may be helpful. It tends to be very high in neonates, but in a 5-year-old or 10-year-old, a random level is not helpful. Growth hormone acts in multiple tissues, including the liver, to produce this compound called IGF. IGF-1 circulates in the bloodstream and could be measured. It, however, is affected by nutrition. So a child who's extremely thin may have a low IGF-1. For those children, we also measure its binding protein, IGF binding protein number 3, which is less affected by nutrition. Measuring both of those compounds will give you some idea about growth hormone production. And again, that has to be put into the clinical scenario. if the child is indeed short. And by short, I don't mean necessarily objectively short, but short for the family, for example. Lower than expected for mid-parental target height. And you monitor this child's growth. Growth velocity is extremely important, probably the single most important tool. So if that short child is in fact growing slowly and the percentage of height decreases, then the next step would be to evaluate IGF-1. And if that's low as well, then we do that 3-hour growth hormone stimulation test, which, even though it's not so reproducible, is still part of the diagnosis of growth hormone deficiency that all the consensus statements have concluded is part of making that diagnosis. Of course, there are concerns. So one of the concerns which we talk about is that the child does not necessarily need to be short, but if the height percentile decreases from, let's say, 75th percentile to 25th percentile, and when you see the child is at 25th percentile, which is normal, but if that decrease in height happens, that child may need an investigation. Once you make the diagnosis, while a pituitary defect is possible, it is not very likely. Still, it would be important to obtain an MRI of the pituitary gland to make sure that there's no either congenital or acquired abnormality. So every child that we make this diagnosis will undergo an MRI of the pituitary gland. Now, that also has to be both done properly with images of the pituitary and reviewed by a pediatric neuroradiologist. In fact, we have a meeting where we review every single MRI that we do. Sometimes there's no obvious abnormality, but the volume of it may be somewhat small. So once we have a normal MRI of the pituitary, we call that idiopathic. And if we have in any patient who we diagnose growth hormone deficiency, it would be essential to look at all the other pituitary hormones. When all the other pituitary hormones are normal, then we call it isolated growth hormone deficiency. It's always a little bit of a difficulty because once we start the children on growth hormone, we continue to treat them if they respond well until they're done growing. And that happens when their bone ages becomes fully mature, more than 14 in girls, more than 16 in boys. When we're done with growth hormone treatment for growth, we reevaluate the ability of the children to produce growth hormone. And we do that initially by measuring IGF-1, and other times is repeating a growth hormone stimulation test, but that's somewhat rare. When we do that in children who have this idiopathic isolated growth hormone deficiency, the vast majority, more than 90%, will test normal. On the other hand, if you have multiple pituitary hormone deficiencies, then the likelihood of it being abnormal is much greater. Now, there are times when we don't need to do a growth hormone stimulation test. So if, for example, the baby has, as I mentioned earlier, an anatomic abnormality of the pituitary gland, or if the children have more than 3 or 4 abnormalities in pituitary function, then a low IGF-1 will be sufficient to make the diagnosis. So diagnostically, worldwide, there are movements to kind of harmonize both the growth hormone as well as the IGF-1 assays, and that's still underway. There's some movement about standardizing growth hormone stimulation tests. But once you make the diagnosis, you start treatment with replacement growth hormone. Growth hormone is now given by injection, daily injection, every day subcutaneously. until the children require growth. Once we start the patient on treatment, we do mention that once we're done with growth, we'll reevaluate the ongoing need, because as you know, growth hormone has metabolic benefits. And for that, we treat growth hormone in adults. For now, the treatment is daily growth hormone. But a few weeks ago, there was approval on a preparation that can be given once weekly. And many other such preparations are under development. In the future, I would expect that weekly, every other week, or perhaps even monthly growth hormone may be considered. Unfortunately, there's no other way of giving it other than parenterally. Any child that we start on growth hormone, discuss possible side effects. Overall, however, growth hormone is quite safe. Very rarely does one see side effects. One could see transient side effects. There have been occasional reports, and was a report in JAMA about long-term issues with cardiac function that have not yet been substantiated. So in general, it is quite safe, but it always there's a balance between the risk and benefit. And for children who have growth hormone deficiency, the benefit by far outweighs the risk. For growth hormone deficiency, growth hormone treatment is unquestionably indicated and by and large quite safe.